My name is Bruce Abernathy. I'm more than happy when asked to come along and just basically MC it. More than happy to do it because I'm a big believer in blokes. We all think we're bulletproof, and trust me, we're not. We're all at that age where you've seen it happen around you. We've just heard John's story. I've had open heart, stage 4, atrial fibrillation and a stroke, and I'm 64. And I've got my first grandchild, I've got 2 more coming. There's a reason to get checked. Talk to your mates, talk to your friends, talk about it. We're going to have plenty more. We're going to have some fantastic speakers coming up here. They've been through it, they've done it all. They're the people you listen to. John's going to introduce them as they go through with their records, etc. Turn your phones off. You've got little pads. Please write down questions. At the end, we'll have the questions. Ask questions. That's the most important. There's no such thing as a stupid question. If that gets one person here tonight, go and get checked and get in early, then we've been successful, and that's what we have to do. We have to be out of here by 9, so we have got the time clock going, don't worry. John's on that too. He's organised, but please, thank you very much for coming. Please be attentive. Please, if you have a question, we'll get back to you later. We're going to ask them all at the end, but at the moment I'll introduce John. We saw him just then. He's put this together. He's come out and he talked about some very personal things, and we caught up last week and it was fantastic to see a guy who was prepared to open his heart, open his frustrations, open his life up to us. But we have to learn. One of us learns, it's success. Here's John Schmidt.
Thank you. I look at the room tonight and I'm pleased that with Steve and the LA Vision group, we've been able to get the room almost full, and that's just makes everything feel, worthwhile. This story that I'm about to say is not about me. It's about the many men out there that have or are having similar problems, trying to live with dignity after treatment. It is about the ripple effect it has on relationships and family. It is about surviving with the hope of a better understanding within family and within community. My journey started with my 5th child, Lauren, who's in the room tonight, was born on the 23rd of December 2001. I went to my GP and asked for a full medical, expecting that every blood test known to man would have been done. He did stick a finger up in a very, an orifice, put it that way. But it wasn't enlarged, and he didn't advocate a PSA, as a standard test, for a 48-year-old. The A of my story is from A to Z, Zoladex. In October 2004, I snapped an Achilles playing tennis, which required surgery, leg implantation for about 12 weeks. Told to keep it elevated, which I didn't. I was a financial planner. I had a briefcase in one hand, laptop in the other, and crutches with a leg in plaster. But after about 4 weeks, I felt pain behind the knee and then went to see my orthopaedic surgeon, who sent me for an ultrasound at Burnside Hospital. The body language on the guy doing the ultrasound was not good. And I asked him what's going on, and he said, you've got a massive DVT halfway up your thigh and you need to go back and see your orthopaedic surgeon ASAP. I did, and the next minute I was in Burnside Hospital on Plexane injections twice daily for the next 10 days. But that night I had 30 guys coming to my boardroom for what we call secret men's business to drink some nibbles. That didn't happen. The injections hurt, and until a nurse about day 3 said, where do you want it? Because they've been putting it in my thigh and it really, really hurt. Plexane injections, I don't know if anyone's ever had them. And she said, well, most people have it in the fat of their stomach. And I thought, okay, and it didn't hurt. But in comes blood specialist Dr. Charlie Wong, who says your PSA is a bit high for your age. And I said, excuse the language, WTF, someone know what that means, is a PSA. He said a prostate-specific antigen test. I said, WTF, what is a prostate? Next urologist, Dr. Peter Sutherland. Next biopsy, Gleason 7. And my second marriage sadly was coming to an end in 2005, so I decided to ignore what was happening until 2006. My PSA had risen to 16. Treatment options were given and I decided on Da Vinci on the 6th of October 2006. The cancer got out of my stomach, out of my prostate, and I had 9 weeks of radiotherapy in January, February, March of 2007. I had done pelvic floor exercises before the op and thought I was about 8% there, but the incontinence started big time. More about that later. I was in an active relationship and the next question was, what about sex? My urologist gave me Cialis, which made me nauseous, didn't like it at all. He said, go and get a penis pump. I went to a sex shop on Unley Road, and luckily the lady behind the counter was a nurse, the mother of the owner. She said, don't buy the expensive one, get the cheaper version, still about $80, but it didn't work. Next injections, prostaglandin, Trimix. Peter said, go down to room 5 and Nurse Sally or Ann will help you. Nurse Ann stuck a needle in my penis. There was movement in the station. I said, how much should I put in the needle? And she said, well, it depends on the individual. And I think Simon will tell us a bit more about that down the track. It did work, it was a bit hit and miss, but required more juice over time, and 100 units was not enough, and I'm not hung like a donkey. I got a bigger needle. But after sex, my willy felt like it had done 10 rounds with Mike Tyson. Again, that's another story. Getting back to my incontinence, I was using pads 24/7. My incontinence was horrible, going through 5+ pads a day. A friend said, go to Nappies Galore. They have a side business of French-made pads and they're cheaper. Well, I went there, but I was still going through 5 to 10 a day. I got to the stage of ordering 10 of 5s from Sydney. And I had pads in my briefcase, my laptop, in my pockets, in my car. I think some of you would know. You know, you just don't know when you're going to get caught short. When I went out, the first place I always looked for was, where's the toilet? I was a financial planner and I had 2 pairs of slacks in the back of my car. I was overly conscious about smell and used baby wipes to clean myself during the day. I used to shave my pubic region twice a month so that the smell was easier to control. I had meetings once a month at the Grange Cafe with colleagues and went to the toilet to change my pad. There was no way to dispose of it. No bin, so I had to put it in a plastic bag in my pocket and sheepishly went outside to put it in a council bin. I said to the owner, would you put a bin in the men's toilet? I can't be the only one that's got this problem. The next time we went, no bin, we didn't go back again. Incontinence was the bane of my life. Sex was my legacy for being alive. So after my new urologist discussed options, I met with Matty Leach. Thank you, Matty. And in January 2017, I had a double op, an artificial sphincter, and a penile prosthesis put in at the same time. My scrotum wasn't very happy with me for the next few months, but the incontinence was under control and my sex life improved, which again is another story. Now, that's the end of my story. My oncologist, Dr. Francis Parnas, commenced me on Zoladex in January 2019, which had the effect of stabilising the cancer. But the cancer started to increase again. At the end of 2020, it got up to 13 PSA. Dr. Parnas was able to get me into a drug trial in March 2021, and darolutamide was added to my medication, which was very expensive, and luckily on the trial I didn't have to pay about $400 or $500 a month. My PSA readings improved remarkably. Within 6 months they were halved, and again. And now I sit on approximately 0.01 or 0.03 stabilised. On the 6th of October this year, I'll be 20 years a survivor. Thank you. Our first speaker up is Dr. Craig Genty, who's my oncologist. He took over from Francis, and he's going to give a short speech about where Dolodex and darolutamide and what's happening in that oncology space. Thank you, Craig.
Thanks so much, John. Thanks for putting us Thanks for putting this together. So I've talked at this venue a couple of times, so I didn't think I was going to be able to recycle the same slides again. So I'm just going to talk quickly off the cuff. It's an incredible time to be able to serve people with cancer, the opportunities for us to change treatments, improve treatments, and test new treatments are manifold. A couple of things I reflect off what John said is that everything's about getting things right for the individual. No one size fits no one, so trying to find the right opportunities, the right treatments for everybody is critical. And clinical trials are a huge part of that. So, I did take over from Francis's practice, which is a great opportunity to come back to South Australia. And we're continuing to offer as many clinical trials as we can get, because while the treatments improve year on year, they're still not perfect, and anything we can do to make them better is just amazing. And it's just incredible to help people in the future and to partner with people who are patients now, but patients turn into participants. They're volunteers who change the lives of other people in the future, so it changes the dynamic of our relationship, and it's incredible. Clinical trials are often thought about as things that come from pharmaceutical companies, expensive new drugs, and that's true, there is some of those around, but how we use testing drugs better is also a really critical part of what we do. So it's always talking to the big companies in the daytime, and then going home and writing grants in the evening to do the clinical trials that we want to do to improve the lives of people in different ways. I work with the ANZUP Cancer Trials Group, which is the cooperative group for clinical trials in Australia for prostate cancer and other tertiary cancers, and we're running a number of clinical trials for prostate cancer, which are incredible. And we've just finished recruitment for a clinical trial that's really important to me, because it's not trying to actually test a dogma that we should give treatment to everybody all of the time at the highest dose for the longest possible time, and it may well be better to give treatment in short bursts to keep a cancer under control. And just like you don't want the weeds in your garden to become resistant to the Roundup, maybe if we use treatments in just the right amount, keep the cancer under control for longer. It's a good idea. It sells well when I say the soundbite, but we don't know if it's true until people go on a clinical trial. So we're very grateful to 84 men across Australia, and it's a trial we're doing with people in the Netherlands as well. So 84 men in the Netherlands who've so generously submitted themselves to a randomisation. Half the men will be asked to take a cancer treatment in the usual way all the time, with no breaks, and the other half is volunteers to take the treatment in short bursts. And it sounds like a good idea, but it's only that clinical trial that'll tell us that it is a good idea. And so it's the courage of people to take part in those trials that's just an absolute joy, and brings me to work every day. So it's always about personalisation. It's always about finding what's right for you. There's no right one solution for every person. And it's important for us to be really humble about the science that we do have and we don't have, and be very honest with people and help them make the best decisions they can for themselves. So thanks again, John, for being part of a clinical trial. It's the only way we move things forwards. And look forward to questions from all of you tonight. Thank you.
Thank you, Craig. Well, Craig will be here with the panel for questions. And he said, well, our next speaker is Dr. Simon Harley from the South Terrace Urology, and he's going to talk about his part in this world called prostate cancer.
Yeah, thank you, John, and thank you everyone for coming along and having me here and putting it all together. I do have, unlike Craig, I am going to recycle the slides, and they'll be up very shortly. For those who were here a few weeks ago, I apologise, it's a very similar topic, but it was what was requested. I think it's very important, and it's great to see so many here. So I am a urologist. I manage all spectrums of urology, and in particular manage prostate cancer, which has a spectrum of either watching and carefully watching it, surgery, radiotherapy, and then Getty gets involved at various stages as well in a very important fashion. What we're talking about today, however, is not going to be about diagnosis. It's going to be because I've managed this. It's a year. So the playing bit. Maybe see it. It's right. Okay. Was that me? So we're going to be looking at survive your life after you've had treatment for prostate cancer. And that might be a number of people in this room. It might be a number of people that aren't in this room as well. So there will be some anatomy in there. There will be some photos with people's pants down. That's urology. I apologise in advance if that's not what you're here to see. We'll just go to the next slide. What I might do. Hold it. If that works. I can't. Oh, okay. Just don't know. Yeah, okay. I'll nod. So we are going to be looking at survivorship because recovery matters, and how your body functions, both sexually and with your continence, really matters as well. So we're looking at survivorship and recovery. So John's talked about it. Urinary continence can affect a reasonable proportion of men. Certainly in the early phases of their recovery, and a number of men even beyond 12 months. Sexual function is also impeded in almost the majority of men, unfortunately, and the strength and well-being of their overall health can sometimes be impacted as well, particularly when we take into account full-body treatments like the ones Craig administers. So you've got your quantity of life back because the majority of men do incredibly well with prostate cancer treatment and their life expectancy is incredibly good. Okay, so it is very rarely a death sentence. So we need to make sure that the quality of our life matches that. So the early phase after your treatment, whether it's radiotherapy or surgery, is usually the hardest. It's where the toxicity of the treatment is most dense. But the majority of men will see improvement over time, but some men's recovery is suboptimal, and that's what we'll particularly be focusing on today. The most common cause of death for men who have prostate cancer is not prostate cancer, it's heart-related issues. So that line's just in there to show you that with treatment, most men will do incredibly well. So we're going to go very basically very briefly to some anatomy. So I don't have a pointer there, but right in front of us is the sphere of the male pelvis, is the bladder there. You then have your urethra, which is the pipe through the penis, and the prostate wraps around your urethra, like my fist around my finger. There are two main issues of the prostate. There is a non-cancerous enlargement of prostate, which gives men their symptoms of difficulty initiating their urine or peeing a lot at night or feeling that they don't empty their bladder. Okay, this is not cancer in almost all cases. Very rarely it can be. What cancer is, it's a small lesion that tends to grow on the outside of the prostate. Because it doesn't encroach on that pipe, it doesn't give you symptoms. And that's why a PSA test has been devised. It's a screening test to try to pick up a cancer when it has no symptoms. The astute will notice there's no prostate, and I've pulled up a female bladder accidentally here, but the principles of voiding is the same. An empty bladder is flat like a Coles bag, and as the urine is created in the kidney, it fills up slowly. And when it's filled to about 500 mils, you get the strong desire to urinate, and it will contract The bladder neck and the prostate relax a little bit, and just below that is a muscle that you control called your urethral sphincter. So that's the one that you can voluntarily control, and it's affected during this treatment. Here's what we do with treatment for prostate cancer. So on the left of the screen is a side-on view of the bladder, the prostate going into the urethra, and on the blue there, those blue things there are the nerves that give you erections. With surgery, we remove the prostate from the bladder and join the bladder back onto the urethra. With radiotherapy, very crudely, they irradiate the whole area. Okay, so that's using radiotherapy to affect the cells and the tissue of the prostate, and there's always a little bit of collateral damage. So first of all, incontinence. This is not a complication of surgery in the first instance, it's a side effect, it's expected. Okay, so in the first 6 weeks, almost everyone is incontinent. We do see occasions where men are fully continent as soon as the catheter comes out, but the majority of men will experience incontinence. At about that 3 to 4 months, we see about 8 to 10 men have restored their social continence, which means they're comfortable going out without leaking. Okay, and if we move on to the right there, we talk about 12-month mark for continence. Depending on your age, a few other factors, the chance of someone being incontinent after surgery at 12 months is about 5 to 10%. Okay, so it's pretty significant. You wouldn't get on a flight with those odds if they were going to crash. But, there's different seriousnesses here. But so there is a reasonable proportion of men that have treatment that will have suboptimal outcomes with their incontinence. Why? That urethra, which is the pipe that we pee out of, gets shortened, which reduces the resistance, which increases incontinence. The muscle that I talked about, which is that sphincter, that's stretched or concussed. Some people already have some bladder dysfunction because their prostate is a bit big, and that can also worsen things. And the nerves that go to the penis will also innervate a bit of those muscles around that area as well. And they get concussed, they get stretched, or they can be removed as well. So treatment is, in all these things, is multifaceted, it's multidisciplinary, and Henry will talk about that as well. So physiotherapy is very important. We can use medications in the short term and long term sometimes. What I'm going to talk about is the surgical options for men who are still incontinent after 12 months and want life to be better. We'll skip through because we'll talk about that shortly and keep going. Here we go. Alright, so the two main options that are available for men that are incontinent are what's called a male urethral sling and an artificial urinary sphincter. What we talked about was that sphincter is usually injured through the surgery, and also the way that the length of the urethra is shortened. So what we're doing with both these operations is trying to sort of artificially correct those. For a sling, this is used for men who have what we term mild incontinence and have not had radiotherapy. That's still sort of up to 400 mils a day of urine leakage, which is about one void is about 400 or 500 mils. Okay, so this is a relatively minimalist operation. I'll just check what slides it is. So we can do this just behind the scrotum. A cut is made. It's about 5 centimetres. And we can site a sling that hitches up behind one of your bones, gets underneath the urethra and it compresses it, okay? And that can provide enough support to the urethra for mild incontinence. This is overnight surgery. You go home the next day, the catheter's in just whilst you're in operation, and incontinence improves almost immediately with that operation, okay? The next operation is for more severe incontinence, or those who've had radiotherapy as well, which is the artificial urinary sphincter. And this is a pretty amazing device, and it was designed about 40, 50 years ago. It hasn't changed because it works so well. But without having a point, I'll just direct you to that bladder that we saw in the initial photo. Just next to that, there is a little balloon that's full of water. This is joined to a pump, which is inside your scrotum, which is joined to a cuff which sits around the urethra. This is all fully concealed, The operation was done through an incision about 5 centimetres once again, with another one a little bit higher, so there's 2 incisions. As a default, there's a little bit of water around that cuff and it squeezes the urethra shut. And then when you have the need to urinate, you pump the little pump that sits inside your scrotum, and that water exits the cuff and goes to the reservoir in your pelvis. And by the water leaving, it will open up, and therefore you can urinate, and then it passively will fill up again and close over. So this is fully concealed. You can obviously see it in the drawing, but no one would know you have it. That's the cuff that sits around the urethra. Once again, it's a short operation, about two hours overnight. For this one, we actually need a bit of swelling and various things to settle down, so it gets activated about 6 weeks later, but can be life-changing for men who have severe incontinence. This is a slide to show patient satisfaction is incredibly high. Next slide. So the take-home for continence is most of them will regain their continence after surgery and radiotherapy. The minority do not. But for those in which it doesn't regain, options do exist. Some don't require surgery, and if you fail those, there's still options that are available for you. I'll briefly check. You've got a little bit more? Couple of minutes. Couple of minutes, give me 2 more. So we'll go on to sexual dysfunction, okay? So, there's many reasons why there will be sexual dysfunction, but primarily, as we skip through the slides, it's got to do with those nerves that go to the penis. So if we just go through the slides a little bit. So just on this slide here, essentially on the left is the prostate, and those nerves wrap around the prostate like an onion skin. And so you can peel those nerves off like you can peel the skin of an onion. The closer you take those nerves off, the closer you get to the cancer. The more nerves you leave in the body, the better erectile function will be. So it is a balance between, cancer, sexual function and continence, okay? So recovery for this takes even longer. It can take 2 years to get to your new baseline. We'll keep going forward because I'm going a bit long here. So sex psychology can be very important. We've talked about vacuum erection devices, which can sometimes give you the function you need for intercourse, but can also just be used for what we call rehabilitation of the penis after treatment. We have tablets, we have injectables, and the surgical procedure is what we call a penile prosthesis. So this once again is a fully concealed prosthesis. In the same way you have a prosthesis in your hip, if your hip wasn't working and it was getting in your way, you can have a prosthesis to achieve erections, okay? With a similar mechanism to the sphincter, the water is in that reservoir, and the penile cylinders that are inserted in the penis are flat and not full of water. And then when you want an erection, it's on demand, you can pump it and the water goes to the cylinders and you will achieve a spontaneous erection on demand. So once again, it's a very good operation for men who want to regain their erectile function. So take home message, intimacy is very important for a lot of men and their partners. Options exist that are surgical and non-surgical, and you don't need to live with those sexual dysfunction. We'll skip through these little bits. But essentially, it talks about keeping fit, keeping strong. You don't need to look like Bruce Abernathy in the 90s, but if you can restore some muscle strength, a lot of your side effects do feel improved. Because these are things that make me happy. You can click through. That's it. No, there's not. That makes me happy. That makes me happy. And the kids make me happy. So if those sort of things, these sort of things are impacting your happiness, there's surgical corrections for you.
Thank you, Simon. So the next speaker is actually Boston Health, and as Simon mentioned, Boston Health had these devices for over 40 years. And I was talking to someone at the back earlier before the presentation started, and he said his brother's put up with incontinence for 13 years. And I said, well, does your brother know about the artificial sphincter? So the next speaker is Matty Leach, and he's actually going to give us some demonstrations, not with me.
Stand up, but
Cheers, thanks John. I don't know about looking like Bruce Abernethy in the 90s, I'd like to look like him now. It's absolutely amazing. I reckon you could put a Guernsey on and go play this week for Paul. I don't have any slides because I knew Simon would speak a lot about the stuff that I would speak about. So I'm going to be a bit of a child and have some show and tell stuff. So I'm going to show you guys what the actual implants look like. And then later on down the track, if you want to come and have a look at them, you can come and see them play. So I've been working in men's health for about 18, 19 years, a different variety of roles. And there's a common theme that I've seen throughout my career, and is that men suffer in silence. And the whole point of tonight's get-together, and I think John's done an amazing job, is that we don't need to suffer in silence. There are technologies out there that will help us to get the quality of life that we had before cancer. And that's where my role comes in. So my role is basically specialising in post-prostate cancer survivorship, and I work closely with Simon and a few other urologists that can put these implants in, and the quality of life, and you can hear from John's story that it does make a huge difference. So the incontinence side of things, the artificial urinary sphincter, it's been out for 54 years. So it's been out for a long time, and it was first actually invented to treat female incontinence. But then there was a market for treating male post-prostate cancer, and that's where it's mainly used today. So with the cuff, think of a miniature blood pressure cuff that when you get your blood pressure taken. It's a small version of one of those, and it's always in a closed position. And then, as Simon said, when the patient gets the urge to urinate, you'll find this pump, and that's the size of it. It's not too big, and then you'll basically, it's in your scrotum, you'll press the pump, and that'll transfer the fluid from the cuff through the pump into that pressure regulating balloon, and it will open up the cuff, and then you'll be able to urinate. And then over about a 2-minute period, the pressure that's generated in the balloon will push this fluid back in and close the cuff automatically, and to try and replicate what we naturally have in this device. So that's the size of the pump. We do about 60 here in Adelaide every year. It's something that I see each and every day. And so definitely, ask questions and there's lots of material out there for you to be able to read and get some answers for. So the next thing is the penile implant, and this is one of my favourite things. Everyone's like, oh, look at this. So I don't know about a kid taking this to show and tell, but it would definitely raise a few eyebrows. But the actual implant itself is this device here. This is the size of the pump that's in your scrotum. This is the bulbous part of the pump here. And you would press that and it transfers. About 6 to 7 pumps is more than enough to transfer enough fluid into the cylinders to give you an erection that you'll be able to have for intercourse. And so this is what this device, how it works. I'm pressing the pump now, it's concealed, and then it's actually quite funny. That's right. And so this is what, 6 pumps, 7 pumps, and then that's the outcome of it. Now the thing of it is that you can have an erection for as long as you want, so you can be a stud for hours, because it'll stay hard until you release it, until you hit the activation button, which is this one here, and then it'll naturally go down. It'll transfer the fluid from the cylinders back into the reservoir, ready for the next time you want to use it. And so, now the thing with this, the thing that I like about my job, and the thing that, in speaking with John and other patients who have gone through this, is the ability to be able to put the power back into your hands. Now, this might not be for everybody. Not everyone might want a penile implant. They're more than satisfied with that part of their life or whatever, but the take-home message is that these devices are here, and that it's designed to be able to increase and improve your quality of life. Because I personally couldn't think of anything worse than working your whole entire life and then looking forward to retirement, playing lots of golf. I'm a fanatical golf person, playing lots of golf and all of those things. To be told that you've got prostate cancer, to beat that, and then to have the side effects afterwards. And so our message is that it doesn't need to be that way. John's a prime example of that, and then how you can get your quality of life back. And so, like I said, I'll be at the back later on. You can come and have a bit of a play. But thanks for your time. I appreciate it all.
Is anyone out there want to try this device? Give it a... No one.
I was going to ask that do you connect number of videos to you can use the RSL.
I think that a bit of levity into the evening, thanks. Manning's actually sat in on two of my major operations. The first time I actually had the double wop, and I had a bit of a problem because I've actually got an overactive bladder, which still requires me to go to the toilet so many times a day, and so I had to actually have a redone. What's the word? That's one. Yep. So the last person I see before I go get knocked out is Batty with his big smile. So we've been mates for a number of years. Now the next speaker is I think follows on, and it talks about more the relationship side of things and the buddying and the friendship aspects of men aren't the best talkers to other men about issues downstairs. So the next speaker, Kevin and I have been, mates I think for over 20 years. We've been on this journey for a long time, and tonight I think is justification for us to keep on this journey and make sure that more men get aware of what is available and what can happen to change their lives. Dr. Kevin O'Shaughnessy.
Thanks, John. A fair bit of what I'm about is actually about John's journey and how it's changed my life, being involved with John along the journey, and also impacted my research. I'm a nurse. I started nursing because my best mate died of cancer when he was 32, when we were both 32. He told me that the best support he got a hospital was a male nurse that was looking after him in the Oncology department of the Royal Adelaide. So when I was looking, we sold the business, we were looking to do what to do with the rest of my life. I thought nursing might be it. It was the big call of my dad to say, look, Dad, you're not going to be a publican anymore, I'm going to be a nurse. And that was it, and he said, no, fine. When I started to look, next slide. When I started to look at taking Stephen Slade's legacy, I like to mention Stephen's name, thank you, and how to take that legacy forward as a nurse. So I was doing all my studies and was able to go forward. I found, looking at it, that the majority of cancer survivors of a male were with this disease called prostate cancer, and I thought I would start to look at that. It wasn't what Stephen died of, but there was a need in this space. I was a novice researcher, I didn't know anything about prostate cancer, and I just started to try and find people to talk to. John, as he just alluded to, was having coffee in Norwood in a cafe with some mates that had also been diagnosed with prostate cancer, and they were trying to work their way through what the treatment choices are and what they should do going from there. One of the things in my journey with men with prostate cancer, it's a bit like how can you tell that they come from Adelaide? If you put two prostate cancer survivors in a room, they'll go, who was your surgeon, what did you have, when was your oncologist, how are you going? So it's about those sort of understanding of what's the journey of someone else. John was at that stage, as we look at each other. He was the youngest prostate cancer survivor I'd met at that stage. He was 48, as he said, when he was diagnosed in 2006. And he was a much younger, skinnier version of myself as well. Following talking to John and then being able to do a survey of men not only in South Australia, across Australia and internationally, we're able to see what were the similarities of someone like John and his mates, and Ian Fisk, who's been always kind enough to support me, is in the room as well. What were their journeys, and were there similarities with the journeys of other prostate cancer survivors? We'll see things we could find. We did that through the responses of the ones of men that came back to us. We saw that at various stages of the journey there were similarities. There's differences, different treatment types, different options, and there was also different questions. So before, when first diagnosed, the fear of death and dying, that hits pretty hard at what to do with the uncertainty around treatment choices. Then after treatment, there's often regret when there's comparing and contrasting against what other people are doing. Some people can have great outcomes. How come he's got a great outcome and I'm still having trouble with incontinence or erectile dysfunction? So that was part of our journey. One of the things that really interested me was often about how men would open up and talk about how it impacted on their emotional lives, and that had been it still remains not as well explored in the literature. So how does it make you feel about being a man, for example, being diagnosed with prostate cancer? So one of my further research was into things around love, hope and faith, that these were important to men diagnosed with prostate cancer, that for some men it felt like, I've had men come and tell me, I just didn't feel like I could be loved anymore. Been married for 40 years, great relationship, diagnosed with prostate cancer, the incontinence and the erectile dysfunction. How can my wife love me if I can't make love to her? Powerful statements like this about how it's impacted their lives, how it changes. Manny was talking about people that love golf. I don't want to go out to my mates and play golf anymore. I just feel embarrassed about myself. I don't go to the footy. I don't catch up with the people. Their wives that are worried about them, saying that I'm worried about my husband. He used to be out every night, socialised. Now he just is withdrawn into himself. So we started to look at this. We started to look at the impact that social isolation, loneliness, as we started this a while ago, and increasingly I saw some of my colleagues again looking at how we reduce loneliness in our community, how important it is, how as the increase of social media, it's been fantastic and lots of information, how people connect, come together on nights like this, how good it is. Yeah, it is. So it's not just prostate cancer alone. One of the great joys of getting older that Abra alluded to and I've lived through is the fact that we have other illness, other trajectories, other things impact on us, and that combination can make us feel less likely to go out, less likely to socialise, and this is important. Men's networks, the way we connect, are often around work or our sport, or there are very different social connections than female cancer survivors have, and recognising how fragile some of those connections are. COVID challenged all of those. The prostate cancer groups are really starting to make some difference in people's lives, got taken away, and they're starting to rebuild and get people back together face to face, and these are important, how we connect. However, it's not hopeless at all. Once we recognise the power of being able to connect, and the power that you have, and the actual self-esteem increase that you get from connecting to other people. So in this room, every second Wednesday, the Mitcham Prostate Cancer Group come together. They're rebuilding from COVID. The men that come in, while they actually feel like they're learning something, they're trying to learn something from themselves, just being here is good for other people. You make a difference to other people when you connect with them. It is not just the little ripple that we have. People's passion, like John, becomes really important. So it's the little things that are important. Make the effort to go to the football, catch up with a mate for coffee, go and do something out of the ordinary because you're making a difference not only in your own life, but their life too. And these simple things make such a difference in how we move forward. So I'm lucky enough in my role that I'm now the Program Director for Simulation, which is where we have simulated hospitals, simulated experiences for nursing students at the New Adelaide University. Because of because of the time put in by prostate cancer survivors like John, Ian and those wonderful people that have helped me with my research, we're able to give back in the way that I educate our new nurses that are coming through. So currently this year we've got over 1,000 first year nursing students. They all get introduced to a prostate cancer survivor. They understand their journey, the fact that they are loved, that they've got a family around them, that often the best support for our prostate cancer survivors isn't nurses that they value or the wonderful team that are talking to you today. It's actually their wives, their spouses, their daughters and their sons are often the people that day to day, week to week provide the support and advice. And sometimes for many of the nurses that go through, it's not the nursing that we're trying to get them educated about prostate cancer, it's their role as sons and daughters of someone that's, or grandsons and granddaughters of someone that's likely to be diagnosed with prostate cancer. Information, understanding that the diagnosis isn't death, that there is some of the ways that this wonderful panel can help improve the lives of them with prostate cancer is what we get them to do. Which leads to our next thing is we're moving forward to a project which John's been involved in as well, which we call the Achieve Project, where we start to look at difficult conversations around healthcare. A lot of our nursing students are young, they're not used to having conversations around erectile dysfunction or end-of-life care or cancer or death or dying, and so we're working on different ways to improve the way we educate those nurses to be able to have conversations. We ask the questions that are appropriate when they do, when they provide healthcare information. So we're inviting people to come together and join us to have some conversations around that. And if you're interested, we'd love you to come and join us. That's who I am. Put Kevin O'Shea to see if you can spell the second part of it into Google. You'll find me happy to talk. And again, just delighted to be able to help John in what he's put together as a magnificent night. Thank you, John.
Thank you, Kevin. The last speaker, and probably pretty important because we talked about, early intervention, getting, treatment and options after treatment. And Henry, I only met him probably a few weeks ago, and yes, I did do pelvic floor exercises, and as I said, I didn't really know until I actually changed urologists that I did actually have a lot of nerve damage in the original operation, and that, with the fact they've got an overactive bladder, just compounded all the components. But the next speaker is Henry, and Henry's going to talk about exercise and other ways to help your body function after treatment. Henry.
Thanks, John. Thanks for organising this. So I will hopefully not be a third generation prostate cancer survivor, but my grandpa and my dad both had it, so my PSA is all good for now.
What down?
And sorry, there wasn't a stitch up about the pointer. When I put your drive in, I took my USB dongle out.
Yeah,
Put it up.
you see this there? Yeah, but yeah.
Okay, there we go. So I'm going to keep it pretty simple. Happy to have a little bit of a chat after. The anatomy pictures that you guys get shown, that Simon's talked about, most guys are pretty useless at remembering them, so I use pictures like this. And apologies for guys that I've treated. I've seen lots of you guys in the room. But we use pictures like this. So basically, you've got your bladder up here, your prostate used to sit around where the tap was, you have your prostate cut out, and you've got the hose down the bottom, and sometimes your tap gets stuffed up when you have your operation. Okay, and that's pretty much it in a nutshell. You've got an elastic rainwater tank though, and so it fills and empties, and the wall of it's actually a muscle. That's it, I've just saved 10 minutes of time if I see any of you guys down the track. Okay? But unfortunately, incontinence is a big issue for lots of you guys. I wish I could say that physio was the be-all and end-all of everything, but as these guys have explained, it's not. And I wouldn't ever sell that it is really important, but there is some research to say that it can be helpful. And again, if you're a betting man, you put your money on something and it might help. Unfortunately, pelvic floor exercises are not only the other thing to help it as well, but we'll go through a couple of things as well. Pelvic floor exercises are important though. Now, can you learn it from YouTube? Yes, you can. Lots of people come in and they are actually really good and they feel like they've wasted time with me, but it's kind of like a golf lesson, and lots of people who are good at golf get golf lessons and they can still get things out of the golf lesson. Lots of people, unfortunately, are really bad at golf and they need to be told that they're really bad and they need to be taught how to do things properly if they want to improve their golf game. So, we don't do any fingers up the bum, and that hasn't been done for a long time, which makes my life really easy and makes it really easy for most men coming in too, okay? The prostate support group out in Port Semaphore were kind enough to be the thanks guys, for the first group where we actually just pulled someone randomly from the crowd and did some real-time ultrasound with them in front of everyone. It's not that scary a thing to do. About a month later than that, I actually pulled up a physio mate in front of his 30 physio colleagues at the QEH and then randomly did it to him as well off the cuff. So I think I was going to do it tonight, but it'll take a bit too long. So you've got to be shown how to do it properly, and that's just with an ultrasound, basically just under the scrotum, okay, transperineal ultrasound. And you've got to be coached through it, and some guys are good, some guys are bad, but you can improve on it. You need to individualise it, because essentially it's like testing everyone here with a gym program. You can't give everyone the same weights to do when they're doing a bench press. Okay, because Simon will probably be able to do about, twice as much as what I can do, and lots of you guys have got other things going on, which would affect how heavy you can lift with your weights too.
We've got a couple of constables here. Is there a Dennis Heath here in the room? He's parked over a driveway. You're parked over a driveway?
Oh,
So if you could get, but they won't handcuff you or...
But we could use some help from the constable for a real-time ultrasound for the no, he's running off. So essentially with your pelvic floor exercises, if you read online, it's 10 lots of 10 seconds, but most guys can't manage 10 seconds. Okay, so you have to look at everyone individually and figure out where they are and then write their program up from there. All right? I've done pelvic floor exercises and I still do. Well, there's lots of other things that come into it as well. All right, we talk about bladder training and getting in good habits, and even John likes his Coke, which is fine, and everyone likes to have a glass of red wine when they're retired. I look forward to doing that too. But unfortunately, sometimes lots of guys don't realise how bad some of their habits are. And it's not just coffee, because coffee affects people differently, but making people aware of what their habits are and how they can change it can make a real difference to their outcomes too. All right? Lots of guys, before their operations, have real problems with these just-in-case weeks, particularly if they've had a little bit of slow enlargement. Now, it's one thing to blame it. I know I'm 70, that's normal for age, but then things change after your prostate surgery, more often than not, and you really want to get on top of it. So a few pointers makes a big difference for some of these guys. Some of you guys. I can certainly lose a few kilos myself, but if there's any time to lose weight, it's before your operation or after your operation. Obviously, if you're going through other forms of treatment, there's alternative reasons why you might want to lose weight as well, or put on weight, depending on what form of treatment you're having. Exercise, food, and fluid. Talk a lot about that and what's healthy. There's a couple of other options that I always talk through with guys about managing incontinence, things like penile clamps, urodomes, catheters. Some of the prostate cancer nurses talk about them in a bit of detail too. One of my colleagues as well, James Georgia, who some of you guys would have probably seen, he's got flyers down there. He's Men's Health Down Under, who stocks some of that gear as well. There is some other things that help. There's lots of washable undies on the markets these days, and they're not that expensive. It's a little bit more than the cost of normal fashion undies these days. And you can buy them all online. They even stock them at Woolies, Coles, Foodland, Drake's these days, the washable men's undies, because it's just that common. And I say to everyone, if you see someone at Foodland who's in there buying incontinence aid, he's asking when they had their operation. And it's almost guaranteed that the bloke next to you has had prostate surgery. I always leave the chair down the bottom there because everyone always asks me about the fancy electromagnetic chairs to stimulate your pelvic floor. Again, if you're really clutching at straws, you can give it a go, but I probably wouldn't waste my money on it, to be honest. But it is an option there. Some people have said that they got a little bit of benefit from it anecdotally. Erectile function, yes. I won't go too much into this because the other guys have gone through it into a lot more detail. No guys ever really want to stick in a needle in their penis to get an injection, but most guys that do it and get a good effect are quite happy to do it. And I think I'd probably be in the same boat if that was a goal. Lots of guys that get on a little bit, might not have been sexually active for a number of years, but lots of guys, I've been very surprised by guys who are 75, 80 and who are still pretty sexually active. And I certainly hope I am at that age too. So you don't assume because someone's young they're still sexually active, or because they're old they're not sexually active. You really need to speak to people about what's important to them for their treatment. So ways around things, intimacy needs to kind of change. People can go back to using condoms if they're worried about getting a bit of leakage. They might not have done that since they were a teenager. And again, surgery is definitely something that can help, as these guys have talked about. I always say don't wait too long. Now, the recovery can take a really long time, but at the same time, lots of guys often leave it too long to start doing anything. So they haven't tried the medications, they haven't tried the injectables for months and months down the track because they're waiting for their leakage to get fixed. But really, you want to be trying to tick things off at the same time, and really don't leave it too long to make sure you tick all those boxes off. Exercise is medicine. So this is my some of the guys in my prostate cancer support group here at the clinic, which is purely the exercise classes. Now, one of the guys, I reckon he can get through his exercises in about 15 minutes if he really wants to, but he hangs around for an hour and he talks a lot of rubbish with the other boys. That's pretty much all he does, which is great. But it is more like a support group than an exercise class. But some of the guys work really hard, and lots of the guys have been coming for in excess of 8 years. Okay, so we do that 3 times a week. It's completely open, there's no bookings for the guys, but it's just an option for guys to come and do it. Lots of guys, including people in this room, really want to go and do their own thing in the gym, or they want to go and do different intensity exercises, and I'll flick them off to PTs or other people I know around Adelaide. So go and get this person up, go twice a week, 3 times a week, whatever you want in your budget, if you really want to get pushed. But at the end of the day, you use your pelvic floor when you're exercising, so another reason to get exercising. The mental benefits and the social benefits are there. The guys always talk about their journeys. Lots of the guys, 3-4 years down the track, have ended up having follow-up radiotherapy. Then they talk about their experiences with other guys when they have problems that pop up as well. Some of them then need to go on to other things like hormones, so we have to completely rejig their exercise therapy based on that. And in terms of erectile function, Simon mentioned about cardiovascular disease being a big killer of guys with prostate cancer. Exercising and cardiac risk factors are one of your biggest risk factors for erectile function. So it's one other reason why you can exercise to try and help get that back up to scratch. Thank you.
Look, the main part of tonight was to have some, I think, keynote speakers that can give you a broad cross-section of subjects that are pertinent to where you are in your journey. I think there's some here in the room tonight that are in probably the stage of making a decision as to what they're going to do with treatment, be it surgery or be it radiotherapy or brachytherapy. But I think the most important part of the evening is going to be question time. So if I can ask the 1, 2, 3, 4, 5 gentlemen to grab a seat, maybe bring them around a bit further so you're facing the audience. Now, Bruce is going to control things now.
And a broken light. Pretty heavy stuff, eh, guys? And also, please give a big thank you to the partners who are here tonight, because we've obviously gathered how important that support is. Thank you very much. And as I said to Craig, Simon, Matt, Kevin, Henry, we've learned a lot. Thank you so much for your time. We'll get some questions. I'll start, but please don't be shy. If you don't feel like you can open up after what you've heard, John, then there's something wrong with you. So if you don't open up, it's not going to happen. I'll even forgive Simon for Geelong and bringing up 119-point loss to Port Adelaide. Lucky we taught you how to win. You haven't won one since '63. Don't worry. It's all good. Erection time. I'm going to ask a question about that because I thought 5 seconds was normal. You can go as long as you like. My wife's going to leave. You have to laugh about it because that's what blokes, we don't do it. We fix up our Monaros and we get our fishing boat going beautifully. We don't actually go and get shit checked out, and that frustrates the hell out of me because I'm 64 and I've got mates who are going through it as well, and that frustrates me. So I suppose the first question is, and I'll ask Kevin this one because it was great to hear your thought process regarding how you make new mates, you make new group of people around you who are sharing that journey. So I'm just wondering how important it is that you actually get out and open up to people around you with what's actually going on in your life, because the reality is they want to support you. It's not, you're not macho man, sorry, you get old, we all get old. You're not going to knock down walls. Welcome to Michael H here today too. He's a survivor. I used to chase him around the football field. We used to be bulletproof in 20. We're not anymore, but it's great to see him here. He's a survivor. So Kevin, I just wondered, how important is it for the guys to actually get that into their system that you've got to open up and be vulnerable?
I think it's crucial. I think one of the things, a diagnosis of prostate cancer has is it exposes your vulnerability, and often for the first time, men look at the end, that this could be their mortality is reflected back at them. So when you're vulnerable as a man, we tend to retreat, and one of the things that can get us out of that space is to do things with the blokes that we know, the people that we've done that with, and that's often about doing something not related to prostate cancer, not necessarily having a conversation. We know that men tend to talk side by side rather than face to face, and gradually over time, when you've got that trust rebuilt, you've gone out, you go to the footy together, it becomes more normal to be back into the community. It normalises how, while you're still feeling vulnerable with your incontinence or vulnerable about surviving cancer, you can gradually, makes it easier to go down to Coles the next day, it makes it easier to do the activities of daily living that we say. I think it's absolutely crucial.
Okay, questions, put your hands up, we'll come out with the microphone, but don't be shy, this is the whole point. You have to open up in front of people. I was going to ask Simon, just quickly, you were quite technical. I'm from Port Adelaide, so how do you just explain to people simply, do we just trust you and go with your word? Because, you're talking about a pretty serious thing.
Is this regard to prostate cancer management or? Yeah, I think that's a really good point, and I don't think anyone should be hesitant about seeking multiple opinions. I think that as urologists, we're usually the first port of call for patients to discuss what their management options are. I mean, I think that there are times that we, or certainly I would bias someone to, either radiotherapy over surgery or surgery over radiotherapy through a number of both cancer factors, but also patient individual factors. But on many occasions, as you're getting into your 70s or mid-70s, and both options are equally effective when cancer hasn't spread. And so it's about the individual, the patient, getting the information that is available to them and figuring out what aspects of their recovery they're happy to accept, or what trade-offs they're happy to accept, based on the information they get from the urologist. But the GP has known them for far longer than I have, the vast majority of the time. So it's not infrequent that they go, oh, well, I might just go check my GP, see what he or she says as well. But chatting to their mates, as you've alluded to, and others have alluded to, and finally, another urologist or another radiation oncologist. There is a spectrum of approaches for managing prostate cancer, and Craig will attest to this. We have a meeting every fortnight on a Wednesday morning where we'd have about 10 urologists and 10 oncologists and 10 radiation oncologists to discuss complex cases, and the opinions can vary. They're often unanimous, but they're often multiple correct answers. So it's often about finding a treatment that suits you.
One question there for that. He's the first bloke.
Hi there, ladies and gentlemen, and thank you for putting this function on. It's fantastic, great news. I'm midway through my prostate journey. Back in March of last year, I was diagnosed that I needed to have it removed. So in October, I had the Da Vinci, had it robotically removed. I was told at the time that the margins weren't quite clear and that I was likely to need some additional treatment, which concerned me, but anyway, it has to be done. So that was in October. Pleased to say that my continence came back pretty smartly, so 6 months later I'm dry as a bone and can do all the normal activities without any risk of leakage, so tick, very happy about that. I have to say, because my nerve bundles were affected, the older fella's dead as a dodo, so there's no cloud pole rising on this bloke anymore, but that's not a big deal at this time of my life.
He's got the answer. We've seen it.
Yes, indeed. But the challenge I've got right now is that speaking to my radiation people, is that probably in a couple of months' time they'll want me to embark upon some radiation this time to knock off the cells that are going a bit crazy. So to give you a bit of an idea, post-operation was 0.017. It's just hanging around 0.02 and stubbornly won't go down. So what I've been suggested is I'm going to need hormone treatment to try and dampen that, and then radiation. But I'm wondering, is there an alternative? Because the other challenge I've got is I got the free set of stenosis. So I managed to get tongue cancer back in February, and my thyroid's up the duct. So I'm looking to try and limit how much aggro I put on this body and get myself sorted out. So can somebody help me out?
No, there's no, is it? It's really hard.
So, look, this is the challenge, is we need to individualise treatment for every person, but we don't have enough science for everybody else, and this is, as Simon says, we sit at these meetings trying to be as objective as possible and give the best opinions, because a lot of the science just hasn't been done. We're getting better and better, but we're trying to give the best opinions. So your radiation oncology specialist will give you advice and certainly won't try and, I don't think, rush you into the treatments. But there are many questions about the treatment that are not yet answered, and so sometimes we have to rely on, this is what the treatment has happened before. It's it's incumbent on us to be honest about that. So in people who've got so-called PSA that has, not recurrence, but is persistent after surgery, then radiation is what is often offered, but the timing can vary. And hormone therapy is often offered, but because of the way the clinical trials were done, there was a situation where hormone therapy was the de facto standard and radiation was added on top. So we still don't have the clinical trials that say that what would happen if you get radiation, but held off on hormones. So we have to be very honest about what science there is and what consequences of the decisions might be that you make, and then be very respectful of the decisions that you want to take if you knowing what you know. And so that's where all of us spend a lot of time just talking to make sure people understand what we do know, what we don't know, and what we speculate, what's custom, what the person who taught me did, and the person before that taught me to do, and then what's actually proven in a clinical trial. So it's really important that we dissect through all of that so that then you can hear that information and then making what's the right judgment for you. But with careful use of radiation, people often do very well. It can have some side effects, but often can be managed with very well. And if hormone therapy is something you do need to take and you choose to take, then the very most important medicine is that IVR, because the exercising and building your physical fitness into it is the best way of protecting all of your functions afterwards. I cannot emphasize this enough. I feel like I should be selling memberships to Les Mills, to the gymnasiums when I'm talking to patients. I cannot emphasize enough how important it is to build an exercise habit that keeps you well, no matter what side effects are treating you at.
Thank you. Down the back.
Les.
Hey, Les. Les Burnett, just by the way, built the Adelaide Oval wicket. He's a god to grass. And he's still giving away pickets from the Adelaide.
Guys, I Peter Sutherland looked after me in 2012 with mine, and I believe Peter's not done so well at the moment, so my best wishes with Peter. I think he's going through prostate cancer, which I don't know the outcome of that, but he mentioned it was on radio not so long ago. But after 2012, I've been lucky with leaking pipes, but I feel like a girl. I've been married for 15 years to the same woman, which is slightly unique. And in doing so, I do feel like a girl. And I'm thinking about I'm getting old, but the rectal pump to give you an opportunity. Does that also give you a better climax, more so than my 2-inch dick?
Well, it is. I'll give you the John Warner story.
Have I got an answer?
Who wants that one?
Yeah, so erection and orgasm are different factors, and you can orgasm without an erection. So
I've worked that out over the years.
Yeah.
It's all by myself.
Yeah, not on your own when you're by yourself. But the device gives you an artificial erection. It just provides a long, straight, hard penis for penetrative intercourse. So yes, it won't feel exactly the same as you recall it to be. Partners often say they wouldn't notice it, and probably 9 out of 10 people are happy with it. What is always the case though, it won't be as long as you remember it. So you do get a reduction in the size of your penis when it's not used a lot. And it's the old, you don't use it, you lose it, and it shrinks. So yeah, that's probably the main thing. But look, if the people that want to restore it, they're looking for better, they're not looking for best.
It's good, Les. I'm going to get home. My wife's going to go, how was it? I said, we talked about dicks and how small they get. Thanks to Les Burnett. Good West Beach resident, great South Australian. And you in America, building those wickets for the Olympics? Yeah, right. Just doctoring what the Indians do. In the middle, down the back here. Next question.
It's a follow-up from Liz's question. Having looked at the various indications, websites, not just in some of the others, it does seem that you can go larger with a penile implant than you might do pre-op or naturally, both in terms of length and girth. So that's my question, can you go larger than you work for? And the second question is how long do these implant systems work for follicular ghost?
I'll start with the last one first. So look, about 10% have an operation in 10 years to either fix a malfunction, replace an aspect of the device, or become infected. So infection is the absolute enemy of any form of prosthesis, whether it's your hip or your penile prosthesis. And that is about sort of 1%, maybe then less than 1%, but over 10 years it's about 1 in 10 do have an operation on it. Going back to your first comment, I would never counsel someone post-prostatectomy or almost ever that they will achieve more length and girth with a penile prosthesis. The erection bodies are essentially like a pillow slip. You know, you put your pillow into a pillowcase, sorry. You can't make it stretch any more than it already is. There are 2 or 3 devices that are on the market and they have particular qualities that may be more favourable in certain cases. So this is, I would embark on it thinking of it as a functional correction of something that you've lost with a gain of identity or regain of your lost identity. Rather than necessarily thinking of it as a new you and something that's new to you by getting a bigger and longer penis.
Done.
In the front row here.
Thanks, Bruce. I was very moved by the ABC Australian story program called Common Ground. I don't know whether you guys here have seen it. It disappeared about 18 to 24 months ago. About two people trying to do something along the lines, and I heard John mention on radio, that we really need to, I'd like every male toilet in the country, every pub, to say prostate cancer is the most curable. You only die if you don't do anything about it. Bowel cancer is hitting people younger and younger. And I'm wondering what the panel would think about bringing in their first PSA at what age, say 40, 45, and then having a line in the sand and then monitoring it, because I was misdiagnosed at 58 and I had all the classic symptoms, and this young doctor said, oh, that's just what you've got to look for as you're getting old. And 18 months later I knew this syndrome, and PSA was only 4. Gleason was 9, and he had his under 12. I've had 2 recurrences. I've been on the drug trial, but the more I think about it, the more I know the prevention is starting. And I'm beginning to think that we should perhaps go to partners. In AIDS, we have better throw him and tell him if it's not on, it's not on. We should probably get partners to name their male partners to, come on, forget a PSA, I want to see what the PSA is. To me, that's, an element to the bowel cancer thing. It's young people are getting bowel cancer, quite astonishing young age.
So there's nothing better at medical conference than getting public health doctors and the urologists and forensics asking them to take PSA screening, because they'll give them to fisticuffs and bash it out. So there's been a long-standing argument about the value of PSA screening, and so we've given lots and lots of mixed messaging. But the future, and the nice thing to say about the future is that using PSA for screening has been what we've kept to use, but there are markedly improving tests coming along. So I spoke last year about a clinical trial that was reported in the last 2 years that's from the UK and uses features of underlying genetic risk called polygenic risk score. So it's actually testing your DNA, and it's not just that really strong inherited family risk that you might have in a few families. But if you get the lottery, you lose the lottery, and you've got a risk of prostate cancer that's much higher. Doesn't matter what your PSA, and that's a group of people we want to screen with. And so suddenly we're getting better tests that will stop that argument about whether PSA screening is a good thing or not, because you need a better test to actually find out what's going on. So that's polygenic risk score. But there's a second kind of test coming, which is going to be really complex. It's not yet worked out, but we can actually start to detect cancer from any kind of cancer, not just prostate cancer, from a single blood test. So looking at the DNA, so every cell in your body has DNA that is the instructions for life. but cancer cells have different instructions, and by being able to detect those tiny instructions, we'll be able to detect all sorts of cancers like bowel cancer, like prostate cancer, and that will have a massive impact on how healthcare is delivered.
We'll do two more, okay?
Sorry, John, can I quickly chime in? So, as I said before, 11 and a bit years ago when my dad got diagnosed with prostate cancer, knowing that my grandpa had prostate cancer, I just elected to get my PSA done every year, regardless anyway, not having any issues, but I would just rather be informed and know and then be on the front foot with anything that's happening anyway. When all my patients, I always quiz them about other friends that might have had prostate cancer, who they speak to, other family members, and just to prod them on, I'll speak with other people and making them aware about your journey will prompt them to go get tested and realise that, waking up 4 times a night to piss is normal.
Comes about that talking about it, doesn't it? Who's got the mic now? Ladies.
I'm just wondering, why has the government reduced the funding for the PSA testing? You can't now be fully funded for a test every year, although I've heard much encouragement that this is a good thing to do.
So they haven't. It means that the doctor has to use the proper writing on the blood film. So if we write prostate cancer on the blood form, there's no charge. But if it's screening, the screening blood test is only reimbursed, I think, once a year. So for people who've got an established diagnosis of prostate cancer, we can order as many as we like, but we don't. But if you have that on a form, the problem comes is that the federal government or Medicare and the pathology providers aren't communicating that well. So people will go along, and then someone in the blood collection centre will say, you're going to have to pay $35 for this, but they don't. So it just means that the doctor's handwriting has to improve.
Yes, lady just in the front with the mic.
Well, I actually think the physio guy answered it for me. I was just going to ask about family and hereditary genetics, that sort of thing. Grandpa had an enlarged prostate cancer, Dad's had it, and now should our 2 sons be aware? They're in their 40s, I don't know when they should go get tested.
I reckon I can answer that. Of course, I need to go and get tested. You want to correct?
Oh, look, the short answer is they probably don't need to get tested. I'm not an oncologist, but I just prefer to because I'm a lot more educated about what the screening actually shows.
Yeah, when we talk about screening, there's the whole population and there's various factors that take into account what a good screening tool is. But generally, if you do have a close family member, and then if you have 2 close or 3 close family members, it sort of exponentially increases the risk of your sons having prostate cancer. Potentially in your scenario, your children should be considering having their first PSA between 40 and 45. And then if it's particularly down below quite a reassuring number, they don't need another PSA until they're 50. But if it is sort of 90, what we call the 90th centile, so quite high, it's probably something that you watch every year until it gets to a particular level as well. And your GP will know that.
Beautiful. Thank you very much. I've just got a quick advert from Chemist Warehouse. Half-price pads until 27th of May, 26. Well done. Away you go. I just reckon there's an opportunity here. We have to be out by 9 o'clock with the RSL so they can get their people home. But I just reckon there's an opportunity for a little more casual, maybe more private social interaction here as we wind it up. Gentlemen, thank you so much for coming. John, thanks so much for opening up. And Steve's going to just wrap it up for us, and hopefully we just get around each other. And the thing I've taken away is share. It works better.
Thanks, Bruce. Actually, a personal note before you, my gleason was 9. My sons my twin boys recommend start getting tested for some 4 when they're 40. That's the recommendation for me. I just got a few thank yous. We're absolutely delighted to see so many people here tonight, but I'm really, really pleased to see so many partners. And also delighted to see so many younger people here now. So obviously the message is getting out, the younger people need to be more aware across this. We think this forum is extraordinarily important, and we hope you've all gained some sort of insight from this. And yes, please take the opportunity to keep talking about this. Thank you for your questions, and thank you for coming. I'd like to thank the presenters themselves for making the valuable time available to us to talk tonight. It's extremely reassuring and comforting to have such quality people and such high quality professionals who can help us in our respective journeys. Their advice and assistance is invaluable, and we really, really, really appreciate it. Thank you. A special thanks to Bruce Abernethy for being our MC tonight. When I contacted him about this evening, he didn't even hesitate, and he simply said, I'm in. And Bruce does not have prostate cancer. He's a good man. Unfortunately, he sleeps in sheets which are black, white and teal. We have a couple of special guests tonight, and I really do appreciate the legendary Michael Ash and the exceptional Liz Burdett attending tonight. A special thank Pangelo, of course, my friend Frank. Frank Pangelo, of course, is also here tonight, and we really appreciate seeing him, mate. A special thank you to the Adelaide Mitchell Prostate Cancer Support Group for allowing us to hijack their monthly meeting. I strongly recommend, if you're not a member of a prostate cancer support group, then please consider joining, particularly a group like this one. They are there to offer you support for men and their families as they continue on their journey. You can find help and support at these groups, and you can even help others. I'd like to commend John Sheehan tonight. He's the architect of this forum. It's his passion. I'd like to commend him for speaking tonight and sharing his extraordinary journey. He, as I said, is very passionate about men getting help with their prostate journey, and believe men need to stand up and speak about embracing their challenges, and we do need that. Men are too quiet. Other organisations have been extremely generous and helped us for the evening. Drake Supermarkets provided things, the RAA, Brace Girls, and Playing the First State. So we've gone and got as much help as we can from different sources. We have a small questionnaire on the back of those pages you've got, the last page. We would really appreciate if you could fill it out. We would like some sort of feedback to let us know how we're progressing, if we need to improve or what we can change, etc., etc. But thank you again. Thank you so much for coming. We do appreciate it, and we hope you gain something from that.
I met Steve by chance. He was a member of the group here, and I can't remember actually how we crossed swords, but he's been my lieutenant over the last few months. His unwavering support has been tremendous, and I think, again, the number of people here tonight are testimony to that. Tonight, I think, has given us a great example of, once people know there is a forum on, through media, through social media, the numbers seem to accumulate. And I've asked, and there are questionnaires on each seat. There's a few questions on the back that if you'd like to answer. The main questions are, is there questions that weren't asked tonight? And one of the questions I think is very valid: should there be a prostate cancer support group for wives and partners and even children?
Yes.
And I think that probably would be a very solid yes. But I think also we need to look at the landscape, the coalface. Support groups do a great job, but a lot of the groups have been run by, let's call them senior citizens, and some groups are wavering because they just don't have the factor to keep them running. Now, I spoke to Will McDonald this morning, and he's been involved in this space through his own journey and also through the infrastructure and PCFA side of things. I'm asking the question whether we need to have focus groups, not a forum like tonight, but focus groups that will be more specific to what you would like to get answers on. It's difficult to get to these professionals, and I'm glad they're here tonight, but sometimes you've got a question and you need someone that's either been in that space or knows what's happened in that space. Just to give you a bit of a starter, and it might be that you are having now erectile dysfunction. And again, I was talking to a guy earlier where his brother's put up with incontinence of 13 years. Now, I question, why hasn't anyone said, why don't you think about some equipment? So, a focus group to me would be smaller groups, husbands, wives, partners, where we can specifically answer questions and have professionals available to us. That it's, maybe groups of 10, 15, where openness will be the key to it. You can ask questions without any problems and know that there are people in that room that are supportive and can help you. Again, look, thanks for coming tonight. Thanks, Bruce. Thanks, Steve. Thanks, Frank, he's been tremendous in getting this happening. Keynote speakers, thank you, gentlemen. I think you've answered a few of the questions here, but I'm sure there's more questions that would like to be asked of you. So if we can stay around for a while, the bar's open at the RSL. They've been a tremendous support for us tonight. Thank you for coming, and I wish you all the best with your journey.
Very good.
I'm